and we'll jump into it. So again, I'm Reed Humphrey, this is Stephen Willis, and we both have been with Canopy for quite a while. We work with hospitals, radiology practices, imaging centers across the country, helping them with their imaging IT strategies. In terms of the goals of our presentation today, we'll just kind of have an overview of the survey that was conducted. We'll share the survey results, as well as some kind of key themes and insights that we've gleaned from the data, as well as some recommendations and just kind of closing thoughts in the end. So that'll be the format. It's probably 20 to 25 minutes will be the length of the session. So first of all, just sort of the demographics of the survey. You guys still able to see the screen?
Yes, I can see your present.
Okay, so we had 78 respondents to the survey from 67 different imaging organizations across 24 states. So it's a pretty good sample set. Obviously not, a representative sample of the entire market. We'd have to survey hundreds and hundreds of organizations for that, but pretty good sample size that helps us see some of the key themes. A little bit more about the demographics. It was a good mix of hospitals, rad practices, and imaging centers. The respondents were typically C-suite. If it was a private entity, typically the president or the practice administrator. If it was a hospital, typically the VP of imaging or the radiology director or IT director. And we also had several radiologists who participated. So good mixed group of people that responded. The breakdown was 28 hospitals and 27 rad practices, so about a 50-50 mix between those, and 12 imaging center operators for a total of 67. The first question that we asked was related to COVID-19. Obviously, when this first came out, this was a very timely topic, and obviously it's becoming more so as we head into the winter. So the question was, has the COVID-19 pandemic caused your imaging department to think differently about its IT strategy or capabilities? And if so, please describe the changes that you plan to make. What we found is that more than half of the respondents said that it has not really changed their imaging IT strategy or capabilities. They have had to make some changes, like more things being done online, more virtual things via Zoom, etc. The ones who said that they have made changes, the biggest change was an increase in remote interpretations of studies. So in response to COVID, a lot of radiologists have had to work outside of the reading room and have had to set up technology in a way that they can read and work remotely, oftentimes at home. So that's been one of the bigger changes that we've seen. The next question was, on a scale from 1 to 5, extremely unsatisfied to extremely satisfied, how satisfied are you with the following? Your radiology IT vendors, your radiology IT systems, and your IT support for radiologists. In terms of vendors, the aggregate response rate was 3.2 out of 5. The systems, the products that are in use, 3.69 out of 5. And the actual support for the radiologist was the highest, 3.87 out of 5. And you can see the detailed breakdown over here as to how it broke down between hospitals, rad practices, and imaging centers. One of the biggest frustrations that we found is just a lack of communication and coordination among the vendors and the products. So, an imaging IT environment is fairly complex. You've got a work list, you've got a PACS, a voice rec system, an archive, a lot of HL7 connections. It's got to flow in and out of the EMR or the RIS. And because of these complexities, there are a lot of vendors and products in the mix. And so if you don't have a coordinated approach with your vendors and your systems, sometimes the systems get out of whack when an upgrade's done. One vendor's not talking to the other, or there's finger pointing. So that's one of the key areas that people said caused frustration in terms of their satisfaction levels. The next question, in a few words, describe your biggest IT and workflow challenges. Stephen, if you wouldn't mind speaking to this, you can kind of see how the trend lines are showing here. Obviously, workflow was the biggest challenge, but you work with a lot of organizations and you kind of hear their frustrations and pain points. How would you, could you speak to some of these and some of the problems that you've seen out there?
Yeah. Thanks, Reed. This is super typical of what we see, even inside a single organization, things sort of ranked like this, if you will, with the overall pain point being, it's just too laborious and hard to get through my day. It takes too much sort of non-interpretive labor. So, and then along that lines, there's the constant frustration of the technology upgrade and sometimes the technology performance around that upgrade. And then a lot of times radiology groups don't necessarily own their own support organization, and so often they feel like they're getting a substandard level of support. And then it's funny, it's interesting to me that standardization came up in this result, because that to me says that we have a pretty educated audience here, because standardization is really at the root of all of this. Because the problem these radiology groups almost always have, or radiology organizations almost always have, is that there's a bunch of different platforms they have to interact with, and a whole bunch of different sort of disparate and non-normalized workflows. And so really at the root of all these problems is almost always standardization. So yeah, really interesting results and super indicative and I think telling of what most radiology groups' true needs are.
Sounds good. So on the next slide, the question was, do you have a unified reading platform for radiology? This is a big trend that we're seeing in the market. Almost every organization seems to be wanting to drive towards standardization of having one PACS and one VR system. Rad groups are wanting to move toward this. Hospitals certainly want to move toward this, and imaging centers as well. Kind of gone are the days, or at least the tendencies of having 5, 6, 7 different PACS and having to toggle between those. This is a day of automation, workflow efficiency, standardization, and in order to do that, the radiologist really needs to have a consistent reading experience no matter where they sit down, in what facility, on what shift, and that's accomplished by a unified reading platform. But when we ask the question, do you have a unified reading platform, 62% of the respondents said yes, and 38% said no. It was about, I think the split was 42 to 25. So the majority do have a unified reading platform, but still a significant percent, almost 40%, do not have a unified reading environment. So there's, I think, opportunity out there. If your group doesn't have this in place, then it's definitely something that is worth looking into. So the next question is, what were the biggest hurdles to adopting investments in imaging IT technology? There were 3 things that rose to the top. There were probably a dozen things that people cited as barriers to adopting new technology or making investments in it. But the 3 that kind of rose to the top were lack of leadership and buy-in. You got to have commitment from leadership to want to make these kinds of investments. Obviously, cost and or budget approval. So cost in the sense of making sure that you're getting a good deal on the things that you're purchasing, and that you've negotiated well. And then budget approval, whether it be for a practice or for a facility, making sure that it fits within your budgeting. So those seem to be the main barriers that people mentioned in terms of doing this. We asked respondents, what technology do you use? And we got a lot of different systems that people responded on. So PACS, VR, interface engine, RIS, VNA, work list, scheduling. And you can kind of see the breakdown here. And again, this is not a large enough sample to be representative of the entire market. But you can see here that, for example, in the voice recognition category, PowerScribe was about 51% utilization. In modal fluency was 27%. There are some other systems like Dolby that fell in behind these, but you know, that's pretty consistent with what you see in the market. PowerScribe is the market leader, but in modal is you know, closing the gap on them, we see from a VR perspective. On the PAC side, Intelerad was the got more votes than any other PACs among respondents. Fuji came in second. For interface engine, it was CorePoint and Cloverleaf, pretty much even. On the archiving side and VNA, Intelerad and Fuji were at the top here again, and that's because in most situations, if you have a PACS, you're also using the storage or the archiving of that PACS. But if you had a true VNA, it might be something separate, like a Terramedica. Actually, Fuji owns Terramedica, so that may contribute to that as well. On the work list side, Clario was #1, and on the risk side, Epic was #1 and Cerner was #2. So that was how the applications shake out. We also asked which of the following best describes your reading environment. And we asked who owns the PACS and the VR system. And you can see the split here. In the majority of cases, the hospital owns the PAC, 42 of them own the PACs, and the RAD groups, 25 of them. I think in this, we also lumped in the imaging centers here with the hospitals. So, so it's definitely the facilities tend to own PACs, and the RAD group uses the PACs of the facilities. But the trend is for RAD groups more and more to own their own PACS environments. They want to kind of control their ecosystem and their destiny. So we're seeing more and more of that. Stephen, any thoughts from your perspective in terms of who should own the PACS in VR?
Yeah, it's a really good question. You know, I think that when we see a hospital system that is a single ecosystem and radiologists are employees in that space, you know, it makes total sense for that hospital to own the entire IT stack end to end, including all radiology IT services. But, you know, the dominant set of clients and hospitals we work with use radiology, you know, private radiology groups or other entities that are non-employed in order to get their imaging interpretation handled. And so with that in mind, it's also, you know, sort of plainly true that radiology groups now quite often serve more than one client. As the average radiology group size, you know, continues to grow quite a bit, and the number of radiology groups continue to shrink, we're seeing more and more radiology groups with the need to own their own technology, just for the simple reason that, you know, it's physically impossible to provide high-level multi-special coverage across multiple different platforms, you know, unless a group is extremely, you know, overstaffed, and no radiology group wants to be in that case. So, you know, with those things in mind, I think this is the majority of the reason, you know, one of the previous slides you went through, Reed, that more and more radiology groups, especially than we saw even 5 or 10 years ago, were taking control of their destiny and owning their own IT platform. So I think that this is one of those things that you're going to see continue to move. You know, these two bars are going to switch places over the next 5 or 6 years, I would say, and probably have switched places in the majority of groups out there. Just these respondents seemed a little bit more heavy on the hospital side because we had a lot of hospital respondents. And so the other thing to keep in mind about this slide is it's probably true that in some of these instances, both groups own their own PACs, which is totally fine. And the hospital's providing sort of the archiving and technologist workflow function, and the radiology group is providing the radiologist interpretation side of the function. They just both have their own PACs with which they can do that.
Great, good stuff. Okay. So on our next question, we asked what percentage of your radiologists are able to work remotely. the breakdown was 65% to 35%. So 65% can read remotely. And you can see on the right-hand side that the breakdown, hospitals by far have 80+% of their radiologists are able to read remotely. Rad practices came in at 55%, imaging centers at 50%. So, you know, it's surprising that in today's day and time where everything seems to be done virtually, that there's still a lot of radiologists who are tied to a physical reading room and not able to read remotely. One of the notes that we have here is that we've seen a significant acceleration in remote reading this year as a result of COVID. So there were a lot of radiologists who just, you know, because the hospitals needed the space or didn't want people coming in unless they absolutely had to, you know, basically told the radiologist, you know, can you please find a way to read remotely? So there's been a lot of setup of home read stations and creating of different kind of bunker environments at the radiologist office, et cetera, to be able to, you know, address the fact that people weren't allowed to come into the hospitals as often. The next question is, are your radiologists using structured reporting in your VR platform? The vast majority said yes, but there's still a significant percentage out there that are not using structured reporting. And, you know, we found that surprisingly, there are many sites that are still using transcription. So Stephen, maybe you can speak to if there are some of the sites that are participating today that are not using structured reporting in a VR platform, maybe still using transcription. Why might they want to consider moving towards VR with structured reporting?
Yeah. I was actually surprised to see this result, to be honest with you. We don't see very many radiology groups at all nationally truly moving to structured reporting. And if we do, we see them moving to it in a super lightweight manner, like just for certain types of exams, but certainly not across the entire exam code compendium. That said, you know, transcription is really hanging on. You know, we're seeing some really large transcription companies do well, you know, over the past few years. That makes some sense, and I suspect some places also we're seeing some use of transcription, but certainly not for all. You know, we don't go anywhere anymore where, you know, portable chest X-rays are being dictated and then transcribed by a transcriptionist and signed off later, or, you know, screening memos or anything like that. But we see a lot of interventional radiology reports and patient letters and things like that still being done by transcription. So all that said, the majority of groups we work with don't use any transcription at all. And this is one of those funny things where often we have strong detractors for a project or an initiative like this who are very vocal during the sales and or initial implementation process. But then, you know, with proper training and especially additional follow-up training and customization to that user's sort of likes, if you will, we see almost invariably those strong detractors become some of the strongest supporters long-term, because the truth of the matter is life's a lot better for everyone with transcription out of the way and voice recognition and signing in real time in place. It's just a matter of making sure that the voice recognition isn't slowing things down. So all that to say that, you know, I think that we're seeing this continue to move in a pretty strong direction toward radiology report, you know, being dictated and voice recognized in real time and signed in real time. And I think we're going to continue to see that trend continue to move as some of those strong detractors kind of age out. Interestingly enough, one of the things we are seeing in this market that is very compelling, I think, as a test bed, if you will, is we're seeing a good number of radiology groups go back to editors to do some work. And by that, I mean, we're seeing a good number of radiology groups as they continue to try to optimize radiologist time to focus on radiology report generation and not all that other stuff, you know, that can consume a radiologist day. we're seeing some of the most progressive groups take literally everything out of the radiologist's hands except for opening up the study and dictating a result. And so with that in mind, what we're seeing is this, on the front side, a lot of radiology groups, having professional radiology assistants to get the study ready, especially high value imaging studies, get it ready, have it hung perfectly, have all the priors there and ready to go and prefetch from other places and good to go. So when the radiologist opens it, they can literally start dictating right then. And then the radiologist either can sign in real time or send to an editor. And if they send to an editor and the editor doesn't have to make any edits whatsoever, voice recognition got it perfect, the editor just lets it go. It's kind of just sitting there in a holding tank. Then if the editor did have to make any type of meaningful change, other than move a period around or take some double spaces out or something like that, they send it back to the radiologist for a quick approval. And all that happens super fast. And so it's not like the radiologist is having to sign back on at 10:30 at night to sign off the reports. I mean, that would obviously be unacceptable to emergency rooms. And even the outpatient world these days is expecting turnaround time quicker than that. So we're seeing that different kind of editor concept continue to hang around just in the name of radiologist speed and efficiency, which is pretty interesting.
Cool. Okay, great. Thanks. So next question, are you using standard report templates across radiologists? I think we kind of covered that, but by the way, the breakdown on it, let me get back to it real quick. Looks like it was more and yes, were the majority of groups that were doing that. Looks like it was about 58% to 42%. Next question, do your RADs provide daily or real-time performance feedbacks on productivity, turnaround times, SLA performance, et cetera, which is something that more and more hospitals are asking for. So the question is, does your practice provide this? And it was about a 50-50 split. About half the practices do and half do not. So Stephen, any thoughts on that in terms of why do you think half the respondents are providing this type of analytics or reporting information back?
Yeah, it's really interesting. In a couple different angles on this, I think. So we might have gotten answers that mean a couple of different things. But one thing for sure we've seen progress dramatically over the past decade especially is the number of radiology groups who provide either real time or at end of day / next morning a detailed report of yesterday's work, if you will. And that is frankly in the name of reducing the standard deviation of radiologist performance across same shift, seats they sit in. And in groups where we've seen them do that, even if it's just a next day report and there's no penalty, there's no governance, it's just information, right? When we've seen groups do that pretty elegantly and keep up with things like conference time and hospital meeting time and things like that, administrative type stuff, we've seen the standard deviations in the same seat, being cut by more than half in groups that do this. And so there's pretty obvious reasons why you want to do it. And I don't find any group who wants everyone to hit the exact same number of RVUs at the end of the day. That's not really anybody's goal. It's just reducing some of that standard deviation to a reasonable sort of band, if you will. The other thing we are seeing some, but less, is this concept of providing that productivity / SLA performance data in real time. And even some hyper progressive practices or practices with more progressive hospital contracts, if you will, we're seeing them display that to the hospital administration or the radiology department administration in real time. And that's always sort of couched inside of we want to help each other do better and make sure our techs aren't holding up the radiologists and the radiologists are getting to the exams we want in the right order we want. And, it's done in a very collaborative way. It's not this sort of overarching, mother watching over your shoulder kind of thing. But so we're seeing that start to grow also now. And I think, frankly, the age of transparency is incoming. Whether you like it or not, it's going to happen. It's just a matter of whether you control how that experience happens or you are subject to how that experience happens if you're the interpreting radiologist. And so we're seeing that grow, and it's certainly interesting times for sure.
Yeah, it's also interesting. Not only is it about a 50-50 split, but if you look at the detail breakdown, it's pretty much 50-50 for each of these categories. So that, I mean, it definitely seems to be kind of a, you know, common theme that, you know, half are doing this and half are not. Okay, so next slide, let's get into the dollars and cents here. How does your organization typically pay for radiology technology applications? And the choices were capital purchase or an operating expense. What we found is that the capital purchase is the more common option. 58% said capital purchase and 42% said an operating expense. The main reason for that is that hospitals typically do capital purchases, and then so most of the hospitals said capital purchase, but then there's an ongoing annual maintenance service contract that comes with that that's usually fairly expensive as an ongoing expense. So even if a system, some technology was purchased with a big check up front, there's still a lot of ongoing fees to maintain and support, kind of care and feed for that system. And then on the operating expense side, you know, this is sort of your traditional fee per study model, where you know, instead of writing a big check up front to, you know, purchase and own the software, you're kind of renting the software on a fee per study basis. And the trend that we're seeing seems to be moving more from CapEx to OpEx, because organizations, one, don't have just the capital lying around, especially not this year, but also because when it's an operating expense, you know, you can just kind of budget for it and set it and forget it. And as technologies change, you can just kind of plug and play pretty easily instead of having this very lumpy, you know, big capital pops, you know, every year or two for things that maybe were unplanned. So it seems like the OpEx model seems to be a little bit more prevalent these days. The next question was around staffing. How many IT employees are dedicated to supporting your radiology department or your center? Imaging centers responded on average 2.5 radiology IT staff. Hospitals 2, and rad practices 3. So this is probably a function of, for example, in a hospital, the hospital has a lot of other IT staff for security, networking, infrastructure, et cetera, that they can lean on for different things as needed. But the actual people dedicated to radiology IT is maybe the PACS administrator and perhaps one other resource. But in radiology practices, the radiology IT staff is the IT staff. So if they've got radiology IT that the practice owns, you know, pretty much anybody that's working in that has got their hands in radiology IT. So that's why we think there's, you know, the staffing seem to be a little bit higher on the practice side. We did put a metric in here in terms of what we see. At Canopy Partners, we typically see 1 dedicated radiology IT staff person for every 50,000 annual radiology exams. So that may help you kind of gauge, based on the size and scale of your organization, roughly how many staff people you should have in place based on your size. The next question, what percentage of gross revenues are allocated to radiology IT? This was interesting on the imaging center side and the hospital side. It was 6%. So 6% of radiology IT revenues were allocated to radiology IT. But on the practice side, it was 3%. And we believe that that is because practices, a lot of practices just rely on the systems in place at their imaging centers or hospitals that they read for. So the burden of the cost tends to be on the facilities, and the RAD groups a lot of times just use the technologies that are in place at the facilities. Therefore, taken as a group, the RAD practices aren't spending as much on radiology IT. But if they want to take on that IT, they're going to have to be prepared to make those kind of investments. And we've seen RAD groups that are allocating as much as 10% of their gross revenues to IT, because they see it as as a competitive edge and a real a differentiator, a way to grow, a way to kind of protect their contracts and strengthen their relationships with their facilities. So IT can be a real kind of strategic asset if you look at it in that way. So we want to take a quick flash poll, and we're going to pop up a polling question now around PACS cost. And the question is, on average, what do you think the going rate is for PACS out there in the market? Just the PACS itself, not the voice rec or all the servers and things to support it. But what do you think the going rate is for PACS? And we'll give you a second to respond to that. You should see the poll pop up on your screen, and we'll keep an eye on the results here. All right, looks like the responses are coming in. So 75% of the respondents that are on today's session chose option 2. They believe that the cost for PACS is between $1.01 and $2. So between $1 and $2. Hold on, the numbers are still changing. 60% now. 60% believe that the cost is between $1 and $2. 40% between $2 and $3. No one said that PACS costs less than $1, nor did they say that it costs more than $3. So, Stephen, thoughts on that? Does that sound about right?
Yeah, based on the respondents of the poll, I think that makes sense. PACS can certainly be had for less than $1, and PACS can certainly be had for more than $3. But that said, I think it makes sense. The 60-40 split there makes a good bit of sense. I think that, just being blunt with the group, I think that if you're paying more than $2 for PACS, just for the software piece of it, you should be looking. But yeah, if you're paying less than $1, I would have some questions about exactly what you got. And so a little bit of both there.
Yep, sounds good. Okay. So next question, we've got, actually we're running over on time, so we need to speed this up. I think we have maybe 3 slides left. Do you share data electronically with external entities? So if you're a hospital, are you sharing data with external facilities that are not part of your hospital? If you are an external center, clinic, rad practice, are you sharing data with, with other entities? And the vast majority said that they are sharing data. Frankly, that was kind of surprising, just because I know that hospitals are really keen on security. But it's good to see that there's collaboration and exchange there, because we think that improves the radiology experience for everyone and patient care when the radiologist can get access to the information that they need via HL7 or otherwise.
Yeah, Reed, I think this might speak to the fact that, especially in today's hospital, where there really aren't but a handful of truly enclosed systems out there in the entire world. Almost no one does their own lab and path anymore. Almost no one does their own radiology, things like that. And so with those things in mind, even the largest academic centers have external partners they just have to work with. And so there's no way to really work with them without exchanging data. In the imaging centers, I think their percentage is 33% of not doing that. I think the reason they can do that is there often are a handful of imaging centers who are truly just in a bubble, and so they can get that done because they don't have external partners they work with. The rad group and the imaging center are all just one.
Yeah, makes sense. So the percentages were 84% yes and 16% no. I think this was probably the last question. What are your top IT priorities for the next 12 months? Respondents said that improving their workflow or items related to workflow efficiency, productivity improvements was 30%. Standardization of their imaging IT environment was also 30%. Upgrading technology or investing in new technology was 20%. and improving their overall IT support. Things like could be staffing, could be the network speed, the security, kind of the things behind the scenes that make the imaging IT work. So these are sort of some of the top priorities that people said. One other question was, is your organization reselling IT services to external entities? Far and away, the vast majority said no, that they're not reselling services. And then the last one was around AI. Are your radiologists using any deep learning-based AI platforms in production reading? We hear a lot about AI. There seems to be, so many different vendors out there with some really cool applications. But in most cases, they're not being used in live settings, at least not yet. Stephen, any thoughts as to when you think AI will kick in, and kind of what the impact of that may be over the next, say, 3 years?
Yeah, a couple quick things on the last slide and this one. On the last slide, you're exactly right. Very few respondents said they were reselling, but you'll notice 50% of radiology groups are reselling. And so if you're a radiology group who's investing in your own technology, I think one of the things we see most often is the ability to resell and capitalize on that technology. I don't know any radiology groups who have a full sort of unified radiology platform that they own and span across our hospitals, or at least selling something back to some percentage of their clients. So that's helpful. On the AI side, I think it's still super duper important to remember that, like, we're just at the first tiny shining lights on the horizon in the dawn of AI in radiology. And even though it feels like we've been talking about it for a while, what we're really talking about here is like technology that's based on artificial intelligence and continually improves and things like that. And, we're seeing a handful of very, very small number of technology sort of solutions being approved for reimbursement. So I think that's a new sort of place that we're breaking through, a little bit on the breast, a little bit on stroke and things like that. And we're finally starting to see a few products do more than just one thing. The vast 95% or more of AI products that were on the market just a couple of years ago could only do one single, really, really skinny thing. So as products begin to be a little more multi-use, if you will, and have 6 or 7 or 8 or 12 different algorithms in them, or can really help you interpret an entire exam, not just one little tiny piece of an exam, and they get better and better, their sensitivity and specificity improves as time, just marches on. And again, like I was saying, as we see more radiology practices begin to understand they can be reimbursed for using these things, or hospitals begin to understand they can be reimbursed for having these tools in-house, and get those FDA approvals and insurance company authorizations, I think that we'll start to see these numbers, these lines start to flip. But to be blunt, the main reason we don't see a lot of AI technology in place today is there's no way to get paid for it. And it's been really difficult to demonstrably say, this makes my practice better, up till the very last year or so.
Yeah, makes perfect sense. Well, hopefully, technology will advance and we'll get there at some point. Obviously, it's not going to replace.
I think it's. No, I don't think there's really any danger of that in the next 30 years or so. But
right.
It's going to get better. There are absolute truck tons of venture capital cash out there betting that it's going to get better. And if you throw enough cash at any problem, you can solve it. So
yeah,
give it time.
Fair enough. Okay, so that brings us to the conclusion of the webinar. We'll open it up for questions in a moment here, but just a few closing thoughts. Just as we sort of comb through the data here, here's a few themes that we thought might be important. One is just to make sure your budget for radiology IT is proportionate to the size and scope of your organization. If you're reading 1 million exams a year and you only have 1% of your budget set aside for radiology IT, that's probably too skinny. So you need to make sure that it's right size for your organization, and you're able to keep up from a technology perspective. The trend that we pointed out of rad groups owning their own reading environments and having unified radiology platforms, we believe will continue. Right sizing your staff, kind of using that gauge of one radiology IT employee for every 50,000 exams. And again, that's kind of a rough ballpark. We believe that efficient workflow is one of the biggest challenges of radiology IT, and that will be continually, that'll be a continuing thing that will evolve of trying to find more and more efficiencies and productivity enhancing things to assist the radiologist. AI will become increasingly more important and integrated over the next 3 years. Seek out ways for rad groups and hospitals to get aligned on radiology IT initiatives. A lot of times the rad groups have ideas of what they want to do and the hospitals don't understand and therefore don't want to let them do it. So you've got to make sure that everybody understands, what's in it for them. And then last, if you're thinking about your strategic plan for imaging IT, you might want to consider having an imaging IT assessment done. That we do those at Canopy. I'm not trying to put a plug in for that, just saying that that's something we get asked a lot to do is, can you guys come in and kind of take a look at what we're doing and make some recommendations? That's pretty much it. We thank you for tuning in today. This was really informative for us to learn what the market thinks in terms of imaging IT, and we hope it's been beneficial for you as well. So with that, we'll open it up and just take any questions. And let me just see if I can unmute attendees. Hopefully there's some magic button that allows me to do that.
With advanced diagnostic imaging.
Hello, Lori.
Hi guys. Sorry,
How are
I'm on my real work computer today, so it doesn't have a camera on it. So you
No
can't.
problem.
That's probably a good thing anyway. At any rate, when you guys are doing your calculation for how much it costs an entity to have their own PACS and basically PACS overlay system, what all are you calculating in as the per study cost? Because that survey was pretty interesting to me, and the information probably could be important to maybe some other people that might be on this phone call from my organization.
So if I'm understanding your question correctly, you're saying if the RAD group were to make their investments in their own system, what are all the components of that would need to factor in from a cost perspective?
When you did the survey for how much per study does it cost for an entity to have its own system, what all are you taking into consideration to rock computation?
Yeah, so we
did the poll we did.
Yeah, we did it pretty skinny, Lori, which is basically just the PACS, because we felt like that was a unit people could understand and might actually know what they're paying. If you try to get into the voice rec and the work list and the archive and other applications like advanced visualization and Mammo, Tomo, et cetera, obviously it's going to add to it. But
then servers and support and network and all that.
We didn't overcomplicate the question. We were trying to ask it pretty down and dirty just to get a kind of a quick gauge. But if you wanted to talk afterwards about more details around what are some of the costs that we see around these different things, be happy to have an offline conversation with you.
Sure. I just kind of wondered if that's kind of where you were targeting and if that was all it, or if that was more inclusive than I was getting out of that. Appreciate it. Thank you.
Yeah, thank you. Appreciate
I might just offer that, normally the actual PACS software itself is the heaviest of the components in this type of environment, and then probably followed by your server and hosting and data center costs, your infrastructure cost, if you will. And then after that, voice recognition, work list, support staff, things like that. Once you average them out over all the studies, it's pretty skinny as compared to those other things.
Sure. Great. That's good information.
All right. Thanks, Lori. Great. Thanks for tuning in. Appreciate it. So, Steve, we have another question that came in on the chat, which is, can you implement a unified radiology platform, I guess, as the practice? Can you implement a unified radiology platform without your hospital's buy-in?
It's a super interesting question. If you want to read the hospital's studies out of that unified radiology platform, so therefore it's truly unified across all the tests you read, then you at least, I mean, at the very minimum, have to have the hospital's, buy-in from just a permission standpoint, because you're going to be exchanging PHI, and you're going to be asking their IT department to do some work, to send you those studies and those orders and whatnot, and then to take results back from you. And so, yeah, I mean, there's no way to do it without having the conversation and at least getting a yes. And then then how much buy-in and what type of relationship you want to arrange from there, is highly variable. And whether you're monetizing that or not might mean something. Whether you're providing specific services outside of just results back to the hospital might mean something. All those different things. I will say also that there's a lot of ways to architect the network connections and security parameters such that the hospital is giving up very, very little risk. And so the real art of that entire thing is how you have the conversation and what you're pitching to the hospital. It's not just, will you let me do so-and-so? The conversation needs to look much more like, we as a group need to do so-and-so in order to provide excellent care to you as a client. So therefore, here's how we need to do it.
Well put. Okay, I think that is it for the questions that I can see. If anybody has a last minute question, feel free to speak up. Otherwise, we really appreciate everybody tuning in this afternoon, and we're actually going to do a repeat of this session next, I believe it's next Thursday. So if you have anybody else that you think would benefit from this, feel free to just message us afterwards, and we'll send you the link to that. Yeah, this was a live session. That'll be a live session as well, but it'll be the same content presented again. So thank you all. Hope everyone has a great rest of the day, and we look forward to speaking with you sometime soon. And thanks, Stephen. Appreciate it.
Glad to. See everyone.
Okay. Bye-bye.